Well, I'm 22 years in practice on the Big Island, and I've survived living in the jungle for 22 years, so that's a milestone. And this is my first year of not having kids, so I'm an empty nester. I have 4 boys, they're gone. So there's 2. How's that? Okay. Hi, y'all. It's so nice to see you. And can I just say that I'm really happy to see doctors instead of providers or practitioners. I see doctors in this room, and I respect you as doctors, and I'm very honored to be in front of you today. Not that if you're not a doctor, you're loved too. Okay, so we're going to talk about some kind of touchy things. So I want to preamble this. I want to talk for a minute about intimacy. What is intimacy? Intimacy is when you take something that is not you and you incorporate it somehow into yourself, right? That's a basic definition of the word intimacy. Humans have 3 basic forms of intimacy that we encounter in our life. And the first, obviously, is sexual intimacy, which today I'm not going to talk about, although I have stories I'd like to know about today. The second one is food. Food is not us, and it becomes us, right? So food is an intensely intimate act. And the third is ideas. So we get very, very attached to the ideas that come into our world that we incorporate into our belief system, and then they become part of our behavior. And in medicine, they become part of how we practice. And we get very attached to that intimacy with those ideas. When someone comes along and says or does something that threatens an intimacy of yours, it is a very normal response to have an adverse reaction to that. So if someone comes between me and my man, I'm going to hate that girl, right? If someone tells me that my favorite food that I think is so good for me I'm allergic to, I'm going to be kind of irritable about that, right? If someone comes to me and says, hey, the way you've been practicing for 20 years, maybe there's something missing there. Maybe there's something wrong. Maybe we've overlooked something. I'm going to have a threatening response to that. And that was my first response to this kind of information I'm going to share with you today. Because I've been treating autoimmune disease the way we all treat it, and we do really well at that. In terms of the conventional model, the naturopathic model is more successful, I would say, than the conventional model. We can all agree on that. But I'm starting to notice that I was missing people, that I wasn't serving them as well as I could be. And then I got sick, and I had horrible autoimmune challenges, and our model wasn't working for me as well as I would like for it to have been. And so I started studying, and I also do low-dose immunotherapy. You guys know what that is? Who does low-dose immunotherapy or low-dose allergy? Okay, something. So it is astonishingly effective for treating allergies, and it's amazingly effective for treating some people with autoimmune disease. Because we think of the autoimmune disease as sort of like an allergy to cells. So LDA can be astonishingly effective, but it's only effective about a third of the time with these autoimmune people. It's effective about 70-80% of the time if it's just, cat finger, right? So I started noticing my LDA patients were having 3 kind of different responses. 1, they responded really well, and then their autoimmune disease cleared up. 2, they had no response at all. Or 3, this is the most frustrating, is they would get briefly well, symptoms would resolve, joint pain go away, sometimes in hours from LDA, okay? Rheumatoid pain gone, moving fingers, amazing, right? But then it would relapse, and I would have to retreat them. And my business model is not where I want to keep patients forever. Like, I want people, I get bored with people. I want them to get well and move on, frankly, and I want to see people. So I noticed this, like, why are you not well? I want you well, So I started thinking about that, and it occurred to me that in our autoimmune concept, we think of an infection as often the trigger. We think there's some insult to the immune system, and it's often an infection, right? Then we think that kind of becomes less important, and we go into this inflammatory stage, and then we go into this chronic immune dysregulation mess. And this is where we all kind of live and where we all treat. And so these were the people that were getting brief response from LDI, but not resolving. And I started thinking, why? Why is their immune system not responding to this? And it occurred to me that maybe they currently still had an active infection, and maybe that active infection that I'm missing is driving the entire process. And what if I went back and treated the infection? So it turns out that I'm not the only one that thought this up. There are some amazing thought leaders in this field, but you have to go back. You have to go in the Wayback Machine to find their work because it's been not talked about very much. One of the first ones was Dr. Weiberg Mason.
And he was in the 40s and 50s, and this is all in your notes, guys, so I don't have to recount the history in detail. You can read about these amazing people. His work started a group called the Arthritis Research Trust, and they had a very active website. They had hundreds of thousands of patients, many doctors, and they treated using antibiotics to treat rheumatoid arthritis. And they claimed about a 70 to 80% success rate doing rotated pulsed rounds of antibiotics. They were MDs, so they kind of learned a lot of naturopathic medicine along the way. So if you go through their treatment protocols, it's so cute because they're like discovering naturopathy for the first time after going to medical school, and they're just so excited. They're like, did you know there's food allergies? And did you know there's this and that? I'm like, I know. So you have to understand that their treatment protocol is layered upon a hacked together base of what we already do naturally. So we're already experts at that, right? So the new part for me was antibiotics. I don't want to do that. That's so allopathic. I don't want to do that, you know? And that's kind of where I was with this thought. And then Ralph came in. And Ralph was a 60-year-old rheumatoid arthritis patient. And he was a very florid, very loud, very energetic person. And patients are your best teachers, right? You have a case and you're like, oh, your whole world changes based on that case. Ralph had one of the most severe ambulatory cases of RA I've ever seen. His hands, he came in alternating between a wheelchair and a walker due to severe pain. And he was in a unique case because he was treatment resistant to all the medications. So the mAbs, nothing had worked for him. Steroids made him crazy. Like he was pretty naive to treatment. So I didn't have to take him off of suppressive treatments to stimulate his immune system to fight this supposed theoretical, in my mind, maybe infection. So he comes in and I'm like, hey, I just heard about this. I just read about this ibuprofen thing. You want to try it? It's like, I'll try anything. I've tried everything. I'll try anything. You know, chart like that, right? So I did LDI on him and I put him on their treatment, which is literally metronidazole 2 days a week for 6 weeks and allopurinol every day for a week. It's in your literature. And I sent him out going, well, I hope that works, right? He comes back in a month later, walking, without a walker, without a cane, without a wheelchair, walking. Okay. He comes up to me and he does like this. He said, I haven't done that in 20 years. I was like, oh, okay. Right? So when that happens to you, when the universe sends you something like that, you have to pay attention. You have to pay attention, right? So that's how I started treating autoimmune disease a little differently. So what else can we talk about here? The first autoimmune disease that was recognized, actually, this is near and dear to Hawaii's heart, was a disease called leprosy. Leprosy, if you did not know 150, let's say 160 years ago, if you did not know that it was caused by a bacillus, you would have thought it was one of the worst cases of autoimmune that ever walked in the door today. So imagine that. Take a picture of a leprosy patient and a picture of a mixed connective tissue disease patient, or, you know, and can you see that? We don't know what we don't know until we know it. And they didn't know leprosy was caused by an infection, a chronic, degenerative, ongoing condition. It was actually caused by a hidden infection until 1874. And that was the first disease we found. So why do we not find it? Because these bacteria are pleomorphic, they're intracellular, and they are not found by conventional laboratory techniques. You take that leprosy and you put it on a plate and try to grow it in a lab, it shows up sterile. So these people were not thought to have an infection, right? So we have to look at things differently from the way we have traditionally been taught to look at them to find this kind of infection. And our techniques for doing that are admittedly still terrible. They're so, like, if you think you have something, like, for example, ureaplasma is epidemic in my small town right now. And we have to order specially for it. It has to be cultured specially. It's very hard to find growing. It doesn't, if you just do a urinalysis, it comes back negative all the time, even though your patient's peeing every 15 minutes and that's, you know, intercourse. You just say, oh, it's interstitial cystitis, right? You don't know it's ureaplasma. Once you know it's ureaplasma, your entire treatment changes, right? So knowledge is power, and if you suspect a hidden infection and you clinically treat it and it responds, then in a way we're obeying our naturopathic principles for treating cause. Because this is one of the causes of active chronic autoimmune. I don't think it's all of them. I think there are people, like if I go back to how my LDI patients respond, so the ones that are responding really well to whatever form of immune modulation we're doing perhaps those people have resolved a chronic infection and now their immune system just needs to be cleaned up and balanced. We have those kind of patients too. And that's about a third of my patients, right? But then this other third that just can't get a grip on it, my response to that now is to circle back around and look at treating infection. So let's talk about how we do that for a minute. It's hard. One of the reasons that I was resistant to doing this talk, resistant to even bringing up this concept, is that treating these chronic, wildly hidden infections is hard. It's hard to convince people that they may have them. It's hard to find them. Our lab testing is not adequate to the cause. We can use autoimmune panels, and those are good and well developed. We have good labs here that do them well, and they show you that your immune system is trying to break through the cell wall of one of your tissues. Right? That's what an autoantibody is. About it. Your immune system is trying to break into a cell of yours. Why? What is the immune system trying to do there? Perhaps one of the reasons the immune system is trying to do that is because there is an intracellular pathogen inside that cell. And your immune system knows it, and your immune system is trying to open that cell up so that it can get in and kill that pathogen. That's how I explain it to patients. Right? So, of course, as your infection gets deeper into your tissue, you would have more and more autoantibodies, and you can track that with labs. So if we go back to how we would start to talk about treating this is a huge topic. I've given you guys a lot of resources that we can find in here. Another treatment approach is a doctor named Dr. Brown. He was working with Albert Sabin, who we all know of, and he found mycoplasma inside the living joint fluid of active rheumatoid arthritis patients. This was in the 60s, decades and decades ago. And so he went off and formed his own treatment protocol for mixed connective tissue disease, rheumatoid arthritis mainly, using anti-infectious agents of various kinds, usually antibiotics, that would treat mycoplasma. And his protocol's been around for decades. It works really well. It's a little bit longer, harder, and slower than the Arthritis Research Trust protocol, but it does work. And one of the nice things about his protocol is you can actually test for mycoplasma. The thing about testing, I got to take a step back. Testing is so difficult because a yes is a clear yes. I found a critter. Okay, a no does not mean there's no critter. It just means I didn't find it. But if you go and tell your patient your lab test is negative, what are they going to hear? I don't have an infection, right? So we have to be really careful how we communicate with people and not in our rush, overlook the fact that there are other possibilities besides the one that we come forth with. So if we're going to treat, let's assume we have a patient in this category over here where they have an active infection of some kind. We found it or we haven't. We've discussed this with our patient. How do we treat it? The first thing to recognize is that most people, at least by the time people see me, they're at the end of their rope. I work in a low-income community. By the time people come see me, they are down. Their resources are depleted. Their insurance is run out, whatever it is. And I have to be brutally efficient. And often they come in and they are on massive amounts of suppressive medications or suppressive therapies. Because that's what we do. We tell this bad immune system, you're misbehaving, spank, let's suppress you, let's make all of your badness go away, and everything will be fine. And if that worked, we would be able to call these people cured, right? But we don't. Autoimmune disease is not curable. So is there something a little wrong with our model if our model is not leading to cure? So we go back to this and we go, all right, so you're on a lot of suppressive things. We have to very slowly get that person weaned off of those suppressive, whatever they are, the mAbs. And we know that's going to hurt them. So we're talking to a patient saying, I think I know what might be wrong with you. There's this historical history in the literature of documentation of why I think this. When I treat you, you're probably going to feel worse. That's a really hard sell. That's a really hard sell. So patient education about this process and selecting patients who can understand it and get through these treatments is critical. And can't save everyone. Not every patient can do these treatments. So I've explained this to some very serious patients, and they thanked me kindly and said, what you're saying makes total sense. I don't have the life left in me to live that path, and I'm just going to stay on my suppressive medication, and I support them in doing that. I wrote a prescription for prednisone right before I left to come give you guys this talk, because that's honoring that patient's choice. Okay, so but you have to take the time to educate them and communicate it down this path. And it can be a painful path. So let's say you take someone who's not on a suppressive anything, hey, you have to support release strongly before you do any immune stimulation therapies. They have to have their antioxidants, they have to have their nutrition, they have to be solid, because we're going to challenge their immune system to rise to the occasion and kill something. Okay, so if they're not ready for that, they're going to fall flat on things. So you have to spend time first balancing, supporting that, and then you have to be ready to palliate. And palliation in this context is not a terminal illness term. Palliation means we're going to manage their die-off reaction, their HERPS reactions, in ways that are not immune suppressive. Because our knee jerk is to go to immune suppressive palliation. So there are a ton of non-palliative supports for people going through a die-off flare. Do you guys know what I mean by die-off flare? Lotus naltrexone is great for this. Lotus phenytoin is one of my newer tools that I think is absolutely fabulous for this. It's a safe, micro-dosed medication that's been around for 50, 60 years. Just thousands and thousands of articles on PubMed about it. And it is about 60 to 70% effective at modulating pain, anxiety, depression symptoms, sometimes within an hour. So I just want to encourage everyone to look in the notes about that wonderful tool. And then on the, Marshall, okay, so the third dude, there's three main dudes in the field of autoimmune treatment of this type. And the third dude is Dr. Trevor Marshall. Who here's heard of Dr. Trevor Marshall and the Marshall Protocol? A few. Okay, not many. Dr. Trevor Marshall is an amazing man. He is a PhD in silico researcher. And he got a very severe disease later in life called sarcoidosis, which is an autoimmune lung disease, which is, long story short, a tissue that slowly grows in the lungs and slowly suffocates the person. There's no treatment, there's no cure. And so because there was no conventionally accepted treatment at the time, he started researching to try and save his own life, which sounds familiar to me. And he had noticed a really weird thing, that his symptoms flared when he went out in the sun, and they got better when he strictly avoided the sun. And that started him thinking about vitamin D and the vitamin D receptor. And so he did some digging, and he found in his particular illness that there were intracellular pathogens, I can't remember the microbe, that have the ability to make, like silly putty or a sticky glue, that they break into your cell. They go into your vitamin D receptor in your cell nucleus, and they gum it up. They don't damage it. They don't destroy it, but they keep it from working. And that has the effect of downregulating 8,000 different steps in the immune system cascade, which suppresses your overall immune function and allows that microbe to live. And then once that bacteria, this is why we start with bacteria when we treat. This is why we go bacteria, virus, fungus, parasite, kind of just the order of treatment. We always start with bacteria because these particular intracellular nasty critters damage the vitamin D receptor. And so something about that made the sun, the sun started reactivating these damaged receptors, and started this immune pathology, which was actually a HERPS type flare. And so that's how he discovered that. So you can go and look at his website, because he's a researcher and he's not an MD. He's done a ton of work at describing this phenomenon, and he came up with a treatment protocol that used a repurposed medication that had a stronger affinity for the DDR receptor than vitamin D itself. So it basically replaces vitamin D in the sick person's system and becomes like super D. So he has people wean off vitamin D because in these cases, the vitamin D is not being very effective. It can't get to the receptor that it needs to get to. And they go on this medication called olmesartan, and you do a clinical trial of 30 days on the medication, and you see what happens. You're either going to get same, better, or worse. So you can explain this to patients very easily. 30 days, have you noticed, are you sane? Meaning maybe this is not your ish. Maybe you actually have something else going on. You get better, which means thank you very much. You turned on my vitamin D receptor. My immune system's working. I killed whatever pathogens are downstream, and now I'm balanced again. Yahoo! That does happen from the Marshall Protocol, 1 month. Or you get worse. And worse is I have a deep pathological burden inside these cells. I've stimulated my immune system to start fighting them, and now it's basically like I have a flu, but not from that critter, from a different critter. So that's how I explain it to people. So they'll notice one of those three event patterns are pretty consistently happening, and you can tell you can guide your course of treatment based on response. So a lot of this is about, I'm going to try something, here's the response, now I'm going to try this, some response. So patient education is huge with that. And then, so now we're at the stage where we've tested, we're pretty sure we have this. We have some palliative tools going in. Neural therapy, by the way, for pain is really good for this too, for pain management. And now we're going to do actual rounds of immune stimulation for these patients. So for the MDs, that means throw a bunch of antibiotics at them, right? Or not just antibiotics, but they also cut down amoeba, protozoa, other kinds of critters too in these treatment protocols. So we pulse these antibiotics or these treatments, and here's where we come in and we do a better job, frankly, because we have so many other better, stronger, less toxic, more efficient tools for actually stimulating the immune system and helping it function better. And so in my practice, I use IV ozone, but very, very low dose, like our wonderful speaker talked about the ozone. It's absolutely true. You start with tiny, tiny doses and gauge response and clear a path for the immune system to respond. And it works beautifully. We use ultraviolet blood irradiation with people. Sometimes with vitamin C, although a lot of these people have oxalic acid issues and don't really feel good on vitamin C. So vitamin C is one that we're careful with. Hyperbaric oxygen. Hyperbaric oxygen is really good because we've got a lot of stagnant, coagulated, toxic tissue that if we just get oxygen into these people, sometimes their immune system can pick up and start killing off these critters. So, what else? Oh, peptides. Gosh, we could do a whole thing on peptides. Who here uses peptides? You guys have peptides in your practice? Peptides are a game changer when it comes to this field because when thymosin alpha became available and I started using it on these people, I used it too strong. And when I used it on myself, my own autoimmune, I used it too strong. So, and I put myself in bed for 3 days with a flare. Like, it was just awful. But sometimes our strongest tools are also our most double-edged swords, right? So if you can take someone and use micro doses of thymosin and just work them up to about a 3-month protocol. There's a really great study, which I didn't cite, of thymosin alpha 1. It's a rat study. Rats. But what they did is they took mature rats, the equivalent of 50-year-old people, and they had a control group and they had 2 treatment arms. And they gave the 2 treatment arms the thymosin alpha 1 equivalent of 2.5 milligrams twice a week for 3 months. That's the human dose equivalent, okay? And after 3 months, they sacrificed group A and they measured their thymus gland compared to control. And these rats' thymus glands were 30% larger. We're talking adult, mature, senior rats, 30% larger. That's not supposed to be possible. We're not supposed to regrow the thymus gland, right? So that's cool. But then here's the even cooler part. They took this group over here, and they waited 6 months, sacrificed these rats, weighed their thymus glands, and what do you guys think? They were the same. They were 30% larger than control. So in rat years, that's like 7 years, right? So the thymosin peptide not only regrew the thymus, but it maintained that benefit. In other words, it is a cure. It's not just a treatment for the immune system. So when I started using thymosin on people, then we started using less and less antibiotics and less ozone and less other things. Because if you can get access to these peptides, and that's, threatened now, so you have to be careful. But there also are oral ones right now too, thymosin peptide oral. So those do also work. So other treatment stuff, one nod to dental focal infection. If your patient has severe gut dysfunction or dental focal infections, all other bets are off. We have to treat that because it will drain their immune system and prevent the other treatments from working. So that's my talk. Anyway, thank you for listening.